There's a major lawsuit going on in at the Navy level regarding AFFF, or light water, aqueous film forming foam, which they used it forms a film on top of JP5 or gasoline or whatever, and therefore can put it out. But they discovered, and to get back to Senator Hutchins' questions, epidemiology tells the story, and that's how they discovered it. And basically, people came in contact with it in training. I even did in the summer 1969, but very briefly. And so the idea that you would get into a population that you know has a higher incidence, in this case, you just heard numbers this morning, 9% and 14%, you know they have this higher incidence, to get into them early and check them out, particularly given that they're firefighters or other first responders. Perhaps your EMS people could be involved also, is important. And I support the bill, and subject to your questions, thank you.
Questions for Mr. Winnie? Seeing none, thank you very much. Others who wish to testify to the bill? Anyone online? Okay. Not seeing further, we will close the public comment. Committee, what's your pleasure?
Move the bill.
I heard move at the same time, so we'll give one of you move and one of you second. Move by Senator Barlow, second by Senator Dockstader. Discussions, Senator. Oh, did you have some? No, okay. Any discussion, questions, amendments? Senator Dockstader.
No, I was just sitting here thinking, in my other day job, I've covered hundreds of fires for the media. All of a sudden, I'm starting to rethink of what I've breathed over the years. Anyway, let's get the bill passed.
Yeah, you should, don't quit breathing. Senator Barlow.
Thank you, Mr. Chairman. This is just makes basically a form, but page 3, lines 15 through 17, there is the way it, this is this was amended language from the House side, and they did it in 3 different sections, Romanet 1, 2, and 3. And this one just reads differently than the others. In the others, they read the type of test and then at medically indicated. In this one, they have at medically indicated intervals, mammograms. There either needs to be a comma there, or mammograms needs to be moved in front of, between at and include. And I guess my suggestion is we move mammograms to on line, from line 17 to line 16, between include and at. So it now read to include mammograms at medically indicated intervals, semicolon. It's just a technical, I think, type of a amendment.
A very good catch.
Anyway, thank you, Mr. Chairman. That would be my motion.
While you're on there, I see something else in that lines 15 to 17 that piques my interest, and that is, why are the cancer screenings for breast cancer for female firefighters only? We have a colleague from the House who had breast cancer, a male colleague, so I'm curious.
So my amendment would strike female as well, Mr. Chairman. I saw it too.
Yep, okay, very good. Would you like to propose that amendment?
It is proposed.
It's
Strike
proposed.
female, insert mammograms between include and at.
Question on that, Senator Hutchins? No. Oh, I thought you were throwing me the peace sign there. Okay, no questions. We'll vote on that amendment. All in favor, say aye.
Aye.
Opposed, say no. That amendment passes. Anything further, committee? Seeing none, let's take a vote, please, Donna.
This is a roll call vote on House Bill 66 engrossed as amended. Senator Barlow.
Aye.
Senator Bouchard.
Aye.
Senator Dockstader. Senator Hutchins. Chairman Baldwin.
Aye.
We have 5 aye, Mr. Chairman.
That bill passes committee. I'll arm wrestle the other 2 sponsors and see who wants the floor manage it. Thank you very much. Senator Barlow.
Thank you, Mr. Chairman. So my apologies to my colleagues in the audience. I have 2 other bills in other committees, so I was doing a little preparation for that. So my apologies. I will be stepping out here shortly because they're up. So anyway, it's that time of the year where crossover and bills are coming up, so I apologize.
And it's a challenge because our committee meets at exactly the same time as House Labor and Health on the other side, in addition to other committees. So
Thank you, Mr. Chairman. Thank you.
thank you for bringing that up. Okay, next bill for our consideration, House Bill 15, Health Insurance Reimbursement of Overpayments Committee. This is a committee bill, so you should recognize it right up front. we can just walk through it real quick. What this basically does is a time limiter for reimbursement of overpayments. I believe it knocks it down to 2 years, not more than 2 years. Everybody's jumping up back there. That's basically what the bill does. And say after 2 years after the date was paid, unless it was fraudulent, that's your limit. It has to be taken care of before that 2 year period. And I think some of those who testify, if anyone wants to testify, that will tell us that's a problem at the moment. So with that, pretty straightforward bill, short bill. Any departments wish to comment on the bill? I knew you were going to shake your head no. Anyone else? Okay, Insurance and Department of Health don't want to comment. Okay, Hospital Association, come on up.
Thank you, Mr. Chairman, committee members. Eric Boley with Wyoming Hospital Association, Wyoming Hospital Association. Sorry, it's early. This is an important bill for us. We're in full support of it. And during the interim, we talked quite a bit about this. Right now, insurance companies have the ability to look back 10 years on claims that have been paid. And from a financial standpoint for any organization, I think having that liability hanging out there is problematic. But when you consider the financial situation that a lot of our small hospitals find themselves in, even some of our larger ones, having the potential of getting hit with a huge repayment is concerning. And I think it was our second meeting, and I can't keep track of where we were. I think it was our second interim committee meeting, but just as we were meeting, one of my larger hospitals got hit with a $750,000 claim that dated back 8 years. If you consider the fact that our hospitals are running on negative margins in some situations, 2% is a great margin at the end of the year. This just creates stability and certainty for them, and so we would stand in support of the 2 year look back. And I think the important part is, you touched on it, Chairman, if it's fraudulent, this doesn't apply, and we agree that if there's fraudulent billing going on, there should be recourse, but this just creates certainty. And with that, I'd answer any questions. Thank you.
Senator Barlow.
Thank you, Mr. Chairman. So you mentioned the 10-year standard. What is that? Where does that 10-year standard come from? It's not in the bill, so it must not be Wyoming law. It must be some other standard from somewhere else. Thank you, Mr. Chairman.
Mr. Boley.
Mr. Chairman, Senator Barlow, I believe it's kind of an industry standard, and there are other states that are taking a look at this as well.
Further questions from Mr. Boley? Seeing none. Thanks, sir.
Thank you.
Anyone else who wishes to testify to this bill? Welcome to the committee. Go ahead and introduce yourself.
Good morning, Mr. Chairman, members of the committee. Hollis Hackman. I'm representing the Wyoming Psychological Association this morning. We very much support this bill. We, at the end of the last session, brought this idea to the House Labor for an interim committee topic because we had providers who had been getting stuck with bills from 3 years past, and for private providers to have to deal with a bill from that far back, it was problematic. So what we did was we found some language in an adjoining state where they had passed some legislation to put a cap on how far back you could go, and the rest is kind of history. So this is a bill that we very much support. I would note that I did some research to kind of prepare for this and talked with office managers from a couple of provider groups to kind of get the feel for how billing goes, because clinicians, we fill out a super bill and then it goes off to office manager or billing department or something like that. And what those folks tell me is that there is something called a timely filing that providers have to submit bills to insurance companies for insurance companies to even consider paying for that bill. And those timely filings are from 3 months to up to a year. So our providers are being asked to respond in a 3 month to 12-month timeframe. And insurance companies right now don't have anything more than the so-called industry standard of 10 years with a look back. So our providers are held to a timely filing kind of a deadline, and insurance companies have a lot more leeway, and that can really create some problems. If you get a rejected claim from an insurance company, folks may have secondary insurance. But if you don't hear back from the insurance company for a long, long time, then billing the secondary insurance gets to be problematic. So if everybody's working with similar timeframes, it's going to be more equitable, and it'll allow people to take advantage of the insurance that they're paying for anyway. So, Mr. Chairman, I would just summarize by saying we very much support this bill. I may have some providers who want to chime in remotely and ask about a shorter time frame, but as I've shared with my colleagues, 2 years is way better than 10 years. And so, Mr. Chairman, with that, I'd be happy to take any questions.
Questions for Mr. Hackman? Seeing none, thank you. Heather, welcome.
Good morning, Mr. Chairman, members of the committee. My name is Heather Roday, and I'm here representing Blue Cross Blue Shield of Wyoming. I'm glad to be here on this early morning. As a little reminder, Blue Cross Blue Shield of Wyoming is an independent licensee of the Blue Cross Blue Shield Association, and as a reminder, all of our decisions are made locally by our Wyoming residents. We support this bill with a look-back period of 2 years. While this bill mentions fraud, it doesn't address waste and abuse. To investigate waste and abuse, it is an industry standard to have a year's worth of data to obtain volume and identify patterns and trends in utilization. A look-back period of 2 years provides enough time for us to gather necessary data and work with providers to remedy problems we might identify through the investigation process. And as a reminder, our members rely on us to be good stewards of their premiums, and being on the lookout for waste and abuse is important to them as well. If timelines are reduced to 1 year, we might have to shorten the timelines for which providers would be required to submit claims, generally accepted to be a year. And additionally, we may have to err more on the conservative side of what gets paid in the first pass. Medicaid has a look back of 5 years. So with all of this said, we agree a shorter period of time for overpayment lookbacks is acceptable, and we do support the current bill language of 2 years. Thank you, and I stand for any questions.
Questions for Ms. Roday? Seeing none, thank you very much, Ken. Oh, here's one, don't run. Senator Barlow.
Thank you, Mr. Chairman. So thank you, Ms. Roday, for your testimony. So you mentioned several other timelines that seem to be more in industry standards than statutory language. One was 1 year, I think, as I understood, for billing. This would be 2 years for once you've received receipt for overpayment. And then 5 years was the Medicaid look back, and we can get maybe more details if Medicaid comes forward. But so my question is, you also, so I just want to make sure those timelines in my mind are accurate. What you brought up about waste and abuse, it seems like waste and abuse falls under fraud if it's actually proven. Is that accurate from your company's perspective? Thank you.
Heather.
Mr. Chairman, members of the committee, Senator Barlow, my attorney friend isn't here with me, but it's my understanding that fraud actually is different than waste and abuse. Fraud has a higher bar that has to be proven, and so they are actually different. Thank you.
Okay, thank you. Further questions? Thank you. I wasn't going to say that. It's live online. Anybody else in the room wish to testify? Department of Health. Yeah, I knew it. I knew we could get him out of his chair. Welcome. Go ahead, sir.
Chairman Baldwin, members of the committee, good morning. Lee Grossman, Wyoming Medicaid agent with the Department of Health. Didn't plan to offer any comments on the bill, just since Medicaid was brought up. Want to confirm that we do have that longer look back period. Ours is actually six years. But two things I think that are of note as you think about this bill and pertaining to Medicaid specifically. One, what we're looking for is fraud primarily. So we have that look back period so that way we can do our due diligence in terms of investigating potential fraudulent cases. We're often working with other partners in terms of various federal agencies in particular with these types of investigations. And second, and I think perhaps more specifically to this bill, Title 26 As a public health benefit plan, our interpretation is that this bill and these limits would not apply to Medicaid. So accordingly, that's the context in terms of how we enter this conversation. And with that, would stand for any questions.
Questions for the department? Senator Barlow.
Thank you, Mr. Chairman. So this is, I understand Title 35, Title 42, Title 26. So just to be clear, health insurance contract, and what you're saying, a public benefit program is not per se a health insurance contract. It's categories elsewhere, notwithstanding this title issue. But my question, so one, I just want to verify that understanding. Second is overpayment. So what is the look back? You talked about a look back for fraud. What if it's just a simple overpayment? What if it's just a billing error, et cetera? What kind of a look back does Medicaid have within its purview for that particular incident? Thank you, Mr. Chairman.
Go ahead.
Chairman Baldwin, Senator Barlow. So one, to your first question to confirm, yes, that is our interpretation in terms of Title 26 and its applicability for the Medicaid program. Now, to your second question regarding overpayments, my understanding is that that 6-year period is essentially across the board when we're looking at overpayments as well.
Further questions? Seeing none, thank you. Anyone else in the group wish to testify to the bill? Seeing none, anyone online? Donna?
I do have a Cheryl Foland online. If she would like to testify, if she'd raise her hand, I can admit her.
Okay, Cheryl, put your hand in the air if you wish to testify. At least virtually, put your hand in the air.
Miss,
And there she is. Can you hear us all right?
I can, thank you.
We can hear you. Go ahead and introduce yourself and go ahead and tell us your testimony.
Thank you, Mr. Chair, members of the committee. My name is Cheryl Foland, and I am a private provider of mental health services in Rawlins, and have been in practice in a couple of different states for over the past 20 years. And I am also representing the Wyoming Coalition of Small Business Mental Health Providers, private providers. We certainly absolutely love this bill. It is far better than what we've had in the past, what is current and in the past. The challenge that Dr. Hackman and others have identified is the timely filing. One of the challenges that we have is if I file with the first insurance provider, and depending on how fast they get back to me, and they're identified an overpayment at some point in time even within 2 years, I don't have an opportunity to file the second insurance company if there is one, nor do I have an opportunity to go look for my clients. Oftentimes once I leave my office, I don't see them again. So for those of us that are a staff of one, and including being the janitor, it can be very difficult. So we would encourage at least further discussion on a lower, perhaps 1 year look back period. The majority of providers, at least in mental health services, are single sole providers. So it certainly affects not only big companies, but it affects us small providers as well. And with that, I stand for any questions.
Questions, committee? Seeing none. Thank you very much. I'm sorry you have to be the janitor as well. Just don't make a mess and it should be good. Thank you very much for coming and testifying this morning. Anyone else, Donna? Seeing none, last chance for anybody in the room. Seeing none, committee will close to public testimony. What is your wish, committee? Moved by Senator Barlow, second? Second by Senator Dockstader. Committee, suggestions, amendments, comments? Going once, going twice. Let's go ahead and do the vote, please.
This is a roll call vote on House Bill 15, Health Insurance Reimbursement of Overpayments. Senator Barlow. Senator Bouchard. Senator Dockstader. Senator Hutchings. Chairman Baldwin.
Aye,
We have 5 ayes, Mr. Chairman.
that bill passes committee. Anyone on the committee with a desire to present that on the bill? Senator Dockstader? Thank you, sir. Okay, let me write that down so I don't forget. Okay, committee, that takes us to House Bill 25, Medicaid third-party payer conditions. Another really short bill. Do we have anybody who would like to present that bill to the committee? Department, go ahead, come on up.
Mr. Chairman, members of the committee, Lee Grossman, State Medicaid Agent with the Wyoming Department of Health. Just a bit of background and context before I jump into the, as you mentioned, very brief bill. We spoke about this early on in the interim. I believe it was our first meeting in Casper. Towards the end of the day, I think everybody was trying to get on the road, so it was a very brief discussion. So in terms of some background here, Medicaid is obligated to be the payer of last resort for all of our claims. So what that means is if someone on Medicaid has third-party liability, some other form of insurance, we need to make sure that those carriers, say if it's commercial insurance, for example, if it's an auto accident, that those insurance carriers are paying essentially their piece of the bill and being primary with Medicaid being secondary. So that's the context in which we brought this to you. A couple of best practices to ensure that we can continue doing that. So accordingly, you'll see on the fiscal note in particular, no impact because again, this is a couple of tools to essentially help us continue in that effort. So with that context, Mr. Chairman, if I may, just very briefly on the bill in front of you. So going to page 2, line 12. So what this does is add a timeline by which if we have third-party liability, again, another insurance carrier identified, in which that other carrier must respond to our inquiries. So that's the 60 days provision. Pretty straightforward there from my perspective. And then down on line 20, also on page 2, a failure to obtain a prior authorization, or excuse me, to obtain required prior authorization. So what this means, and I think it was in line with the bill we were discussing, especially during the interim and that topic on prior authorization requirements. This is very simple in terms of if the Medicaid program is seeking reimbursement, or as we call it, post-payment recovery on a claim that was already paid out, that request could not be denied because the department did not get a prior authorization through that carrier before the service was delivered. So all this being said, let me give an example because at least in my simplified mind, I have to try to think, how will we see this in the real world? So let's say there's someone who is on Medicaid. They have an accident, maybe a car crash, something of that nature. They receive services. Let's say it's not even in their home community. The hospitals and the clinicians, of course, do their good work, get that person all good to go. They know that person's on Medicaid, so they will bill us. Later, we have ways of verifying and seeing if there's other, let's say, private coverage, especially in the case of an auto accident. There's additional insurance there, of course, for Medicaid to pursue as the payer of last resort. So that way, again, we can make sure that these public funds and taxpayer dollars are being conserved for these instances when folks do not have other coverage. So those are the types of, and again, just one example, hopefully that will help illustrate this. When we go to verify that information, if we identify that third-party liability coverage for the reasons specified here, that carrier could not deny Medicaid seeking the post-payment recovery. So again, very simple in terms of just a couple of changes that that will help us align with best practices and making sure that we're keeping Medicaid as a payer of last resort. With that, Mr. Chairman, stand for any questions.
Questions, committee? Senator Barlow.
Thank you, Mr. Chairman. So again, in this bill, there are timelines, and what I'm actually interested in is the current timeline of 3 years, line 15. So this is respond within 60 days to a claim that is submitted not later than 3 years. And so that's now about the fifth timeline that we've heard today. So I guess my inquiry about the 3 years, is that a federal component? Is that something that's completely within Wyoming Medicaid? I think we've heard some other testimony that 2 years is, or 10 years, I mean, we've heard a lot of different things. So just give me the genesis or the basis for the 3 years, besides that it's in the green books. Thank you, Mr. Chairman.
Go ahead, sir.
Chairman Baldwin, Senator Barlow, great question. In terms of the federal component, I'm not aware if that's a federal requirement, other than just seeing it here in this component of statute. So this is a little different than some of the timelines we spoke about on the prior bill. That's looking at, again, things like overpayments, fraud investigations, those types of activities. This one here, in my interpretation, is really looking at if we identify that third-party liability up to that 3-year timeframe, that we would be able to, again, inquire to that other third-party liability carrier.
Follow up, Senator Barlow.
So, Mr. Chairman, I like consistency and everybody playing on the same field. So this one actually feels a little odd, i.e. it's an odd number as well. But we've been thinking about 2 years from some other things. It seems like maybe we should, I may not propose an amendment, but I just throw it out there that I like consistency if we're going to treat the private side, because this is the private side that they would be getting a claim 3 years later, potentially after the service. So anyway, thank you, Mr. Chairman.
Senator Bouchard.
Thank you, Mr. Chairman. I get what the senator's saying, but those are clawbacks on the other bill. This is basically giving them 3 years to find if there's another insurer. So it's a different situation. I don't know whether we need consistency in 2 years in that same situation. So it's just
Hold that thought when we get to committee discussion. Further questions for the department? Seeing none. Thank you, sir. Anyone else in the room wish to comment on this bill? Insurance, no. Okay. Anybody online, Donna? Okay, in that case, we'll close public comment. Committee, what's your pleasure? Moved by Senator Dockstader, seconded by Senator Barlow. Discussion committee. Comments, amendments, seeing none. Let's do a roll call, please.
This is a roll call vote on House Bill 25, Medicaid third-party payer conditions. Senator Barlow. Senator Bouchard. Senator Dockstader. Senator Hutchings. Chairman Baldwin.
Aye.
We have 5 aye, Mr.
We
Chairman.
have 5 ayes. Senators, anyone wish to carry this one on the floor? Speaking. Senator Barlow will carry that one on the floor. And that brings us to our final bill for the day. House Bill 24, Certificate of Need Repeal. Another committee bill, perhaps the shortest bill of the day, but perhaps the one that will receive the most comment. Anyone out there wish to present this bill to us? We can walk through it real quick if you'd like. Okay, I will. What this bill essentially does right now, there's a law in the book, in the green books, about certificate of need, that if any healthcare facility, nursing home, et cetera, wishes to expand or improve, that has to go through the Department of Health and for any kind of approval. And the purpose of that was not to expand these things beyond what the capacity of the state is. When we brought this up in committee, it was felt that perhaps there's no need for that certificate of need anymore, that perhaps we could repeal it. And whilst having these plans approved, not having that actual cap so that we can expand if needed, the number of beds, the number of facilities, et cetera. That's, in a nutshell, that's what the bill talks about. Any further things anybody wanted to say about the bill before we move it out to the public? Okay, let's hear some comments. Department, I didn't see you back there, Director. You were hiding in the background. Welcome.
Good morning, Mr. Chairman, members of the committee. Stefan Johansson, hiding in the back of the room, Director for the Department of Health. Just some brief comments here, maybe a little bit of refresher history from our discussion over the interim on the Certificate of Need. Certificate of Need provisions have been around in virtually every state, really going back to the mid 80s and early 90s, when states put these provisions in place for a couple of reasons, primarily to, as good chairman pointed out, to make sure that capacity in long-term care, again, Certificate of Need is specific to nursing facilities, to ensure that the capacity that was there was meeting the demand and not overbuilt for the demand that was there. Primary reason for that, if you go back in the history books, is really because your public payers, i.e. Medicaid and Medicare, are really the vast majority of the market for long-term care or nursing home reimbursement. Now, over the years, these discussions have evolved. The feds actually pulled back their Certificate of Need requirements many years ago. And so states have started to look at, is this necessary and relevant to have sort of a public mechanism for lack of a better term, interfering with market mechanisms? And it's a good question, and really was the discussion the committee had over the interim. I will say from the Department of Health's perspective, there's pros and cons to Certificate of Need. On the pro side, again, really ensuring that communities or certain geographies of a state are not overbuilding long-term care capacity and thus putting pressure on public payers, which are the main payers for these services. On the con side, and I can give you some examples, you potentially have high-quality nursing facilities in your communities that have a waiting list and want to expand because there's a natural market demand signal there to expand the services that are clearly popular in long-term care and are sometimes or historically unable to do so because of the Certificate of Need restrictions, meaning if your capacity in that geography is less than 85% of all facilities, then one facility is only allowed to expand virtually 10% if you look at the statutes. And that has not often, but presented some difficult situations in Wyoming and in other states that a high-quality nursing home with a long waiting list or significant demand is unable to meet that demand. Whereas you might have a lower quality nursing home that does not have a waiting list and in fact has many empty beds. There's a lot of reasons that I won't get into of these pros and cons and hypotheticals we can discuss of, can facilities right now staff all of their beds? No. Is that related to Certificate of Need? Not necessarily. We've seen significant staffing issues across the health and human service industry over the past decade, but really heightened over the past couple of years. And so there's a lot of reasons for capacity issues in the industry in general, and certainly in long-term care specifically. Your Department of Health, through our Office of Healthcare Licensing and Survey, is the entity that has been responsible for applying and enforcing Certificate of Need since it went into the Green Books decades ago. Ms. Laura Hudspeth, to my right, is our administrator of the Office of Healthcare Licensing and Survey. Her team, lean and mighty team, do a good job with all things healthcare construction, licensing, survey, life safety code, and Certificate of Need is one element of that. Essentially how it works is if a facility wants to expand, they submit a Certificate of Need application, for lack of a better term, which gets reviewed based on the statute. You look at that geographical radius, assess the capacity of all long-term care facilities in that geography, and then determine does Certificate of Need apply or not. The amount of requests that we've received are relatively low over the past 10 years or so, but they are there. And there have been a few instances where we've had to make denials of those applications to construct because the statutory Certificate of Need was essentially in play, meaning in that certain area, the long-term care bed occupancy was less than 85%. So that application would be denied. Your Department of Health in this bill is neutral. Again, there's pros and cons. We don't see a huge issue with the Certificate of Need repeal. But I think it's worthwhile to monitor that going forward just to see what the market dynamics are, what the bed capacity dynamics are going forward. And if you look at the bill, Mr. Chairman, Section 2 On page 2, line 12, that's really your straight repealers. And all of the sections in Title 35 that are relevant to certificate of need are repealed. Again, no major issue from your Department of Health on this. I did want to go backwards and just point out something in section 1 that was amended on the House committee side and held on the floor. This is also a section that deals with certificate of need, but also with the broader life safety code construction reviews that the Department of Health Office of Licensing and Survey conducts. So you'll see an amendment starting on page 2, lines 4 through 5 and lines 8 through 9. Originally, this had read that our approval was removed and in favor of commenting on it. And I think the intent from the committee during the interim period was to remove our review and approval on the certificate of need specifically, but unintentionally, in my view, amended this section, which also deals with preliminary construction plan reviews on all healthcare facility construction, not just life safety, or excuse me, not just certificate of need with nursing home facilities. So a good amendment was brought, I think, in partnership with a few folks that'll probably speak behind me, to make sure that our review and approval is specific to healthcare and life safety compliance only. The reason for this, Mr. Chairman and members of the committee, is I think there's a good function that our office provides when any healthcare facility wants to have a construction project or expand anywhere, and again, not just talking about long-term care here, where before they submit their or go through their construction project, they submit a preliminary construction plan that our engineers and professionals review to determine kind of preemptively and from a preventive standpoint, will this be in compliance when we come months or even years later after the project come to survey for healthcare facility and licensure and life safety code compliance. In my view, it's a good preliminary review to have because we prevent potentially significant costs on the back end where a construction project or an expansion happens, and then we come in with the hammer, a year later to do the survey and say, you were out of compliance here, this piece of equipment or this sink has to be moved, and you're potentially looking at tens, hundreds, and in some large projects, hundreds of thousands or millions of dollars on the back end. This is a good preventive measure, and again, I think the House side amendment really takes care of what the department would suggest to keep that review and approval in place. That's really a service, in my view, to the industry before being punitive on the back end with survey. With that, Mr. Chairman, Laura and I are happy to answer any questions you might have.
Thank you, Director. And I'm just looking on page 2 there, the look back period, back to September 21st or September 1st, 2028 to report back to the committee. Is that sufficient?
Mr. Chairman, agnostic on that provision. We're, as you know, happy to report to you at whatever frequency you would like. I can't guarantee that the governor will keep me around until September 2028, but happy to do that if I'm here.
We'll put in a good word for you. Senator Bouchard.
Thank you, Mr. Chairman. So I want to go back to this preliminary inspection. When let's say this comes up, is there a fee for that inspection and the report that comes back, or how is that? I mean, I look at this stuff and I hate it when I see things where projects are held up. So I'm just trying to see what that process is and how much it costs.
Mr. Chairman, if I could have Ms. Hudspeth answer that.
Go ahead.
Our Chairman Baldwin, Senator Bouchard, Laura Hudspeth, Healthcare Licensing and Surveys. There is no charge for our plan review or construction inspections for these projects. So we do not charge for the services. We have engineers on staff who do those reviews and on-site inspections.
So just one follow-up, Mr. Chairman.
Go ahead. Yeah, Senator Bouchard.
So is there a timeline that has, like, if a project is requested or a inspection or preliminary inspection, what's the timeline there from the time that they start and say, hey, we want to do this? I'm looking at that window. I want to know what that is.
Mr. Chairman, Senator Bouchard, our timeline for a major project for a plan review is 60 days. It's 45 days for a minor project. And then in terms of our inspections, it really depends on the the building project, the construction company, the time of the year. Our engineers really are very flexible to make sure that they help meet those needs to ensure that these projects, these buildings are built and constructed in a timely manner.
Follow-up?
One last, so is this in-house? I mean, how many engineers do you employ? And I mean, how much staff is used to do this?
Mr. Chairman, Senator Bouchard, we have three full-time engineers, and the majority of their time is on plan reviews and construction inspections. They also do life safety code and emergency preparedness surveys for the Centers for Medicare and Medicaid Services in these facilities.
Okay. Further questions, committee? Thank you very much. Okay, anyone else in the audience wish to discuss this bill? We know this guy. Welcome, first time in our committee this year. Go ahead, sir.
Yeah, thank you, Mr. Chairman and members of the committee. My name is Tyler Lindholm. I'm the State Director for Americans for Prosperity here in the state of Wyoming. And I wanted to touch base a little bit, Mr. Chairman and members of the committee, on the history of certificate of need laws in the United States. They first came about in 1964 and it started in New York. As is such, as I suspect you can probably surmise, ideas from New York don't tend to go very well. And over the years, the intent was to contain the costs. That was the original intent of certificate of need laws. As it turns out, by restricting the number of beds in an area, that does not restrict the cost of healthcare. And in fact, it was quite the opposite. In 1982, the federal mandate was put in place that states needed to have a certificate of need law, and it took them 5 years until 1987 to repeal that mandate. And as we've seen, even in the state of Wyoming in the 90s, when they repealed certificate of need laws for healthcare facilities, what we've seen is that there is little to no significant difference as far as beds, staffing, those types of things. Certificate of need laws, as the Wyoming Department of Health just stated, actually has restricted access in the state of Wyoming. There's been facilities that haven't been able to be built. Specifically, Mr. Chairman, if you look at the repealers, you'll see in 352906B, that's the 85% rule. So, Mr. Chairman, members of the committee, if a facility is under that 85% and there's a new facility that's wanting to be built and it's within that 30-mile range, Mr. Chairman and members of the committee, is under 352901A5, then it can't be built. That new facility will be denied if it's under 85%. So we have to ask how many facilities are at 85% or over. And Mr. Chairman, members of the committee, in the state of Wyoming, there is one. Your average percentage is 70%. So with this existing law, if that stays in place, what we can assure ourselves, Mr. Chairman and members of the committee, is that facilities will not be built, regardless of what the free market says, regardless if somebody wants to waste their money and build a facility that the state thinks will not be successful. They should have that right, Mr. Chairman and members of the committee. And so that's why specifically, Mr. Chairman, Americans for Prosperity is on and in favor of this legislation, particularly with the House amendments that were put in. I think that cleans up the intent of the law. It's specifically in that section 1 that cleans up what your intent was just a couple of months ago from committee, Mr. Chairman. And with that, I'll stand for any questions.
Questions for Mr. Lindholm? Seeing none. That's the easiest testimony you've ever given, sir.
Thank you, Mr. Chairman.
Thank you. Further comments? Come on up. Welcome. Go ahead and introduce yourself.
Thank you, Mr. Chairman, members of the committee. My name is Chris Mickey. I'm with the Wyoming Business Alliance. You heard a lot of my points already given by Mr. Lindholm, so it's always hard to follow him. But the Business Alliance is Wyoming's premier business advocate and proponent. And so because of that, we support this bill. We feel this is a really good pro-business bill. And as Mr. Lindholm said, we feel that businesses should have the opportunity to grow and thrive in the state of Wyoming without having to go through the government. So for those reasons, we just really want to have your support on this, and I stand for any questions.
questions? Committee? Seeing none. Thank you very much. Anyone else out there wish to comment? Welcome. We've seen you before. Oh, no, no. It's always a pleasure. It takes me back to high school. Go ahead, sir.
I'm Gary Crum. From Laramie, Wyoming. I'm here on behalf of myself, a Rollins native, a Wyoming native. I am strongly in favor of the repeal of the 85% rule. Being a banker in the state, had a couple of opportunities where people have wanted to build new care facilities and have been able to do so because of this 85% rule. So I'd be strongly in favor also. Having had family members went through that this summer in Saratoga, in that we just need a chance for free markets to participate. If somebody fails, they fail, but we need a chance for free markets to take place and improve our long-term care facilities here in Wyoming. We've seen a really good, in my opinion, example of that in Carbon County in Saratoga, where they did have a nursing home end up having to close, which was a tragedy. But what happened? The community got behind a need, built a hospital with long-term care beds in it, and did it privately and with some funding. The community took it upon themselves to fill that gap and fulfill that need. And I think that's just a really good example of people stepping up where they need to and taking care of things if a free market is allowed to take place. And in that case, it was, because there was nothing there to prevent it when that nursing home failed. So with that, I'm also in favor of the amendment that was put in with the approval process. Makes a lot of sense. If any of us would go build a home, we go to the city planner, have them approve our project before we start building the home. It's very similar here, so I'd be in favor of the amendment as well. And thank you for your time, and if you have any questions, I'm open for that too.
Questions for Mr. Crum?
Not specific to
Senator
this bill,
Dockstader.
Mr. Crum, but when Carbon County, when they put the hospital and the nursing home together, do you know how they run that financially?
I believe so,
Two
yes, sir.
separate entities?
In Saratoga, yes, sir.
Or in Saratoga?
Yes, sir.
It's all one?
And Rollins has a nursing home and a hospital as well.
Yeah, but they combined it all in one.
Yes, sir.
So how do they handle it financially?
I'd have to, I can't tell you, sir. I'd be guessing.
Okay, thank you.
Okay. Very good. Further questions for Mr. Crum? It's always good to see you, sir.
Likewise, Mr. Chairman.
Almost 50 years ago, he and I played high school football together, so. Yeah.
Exactly. We won't say
Now-
who won.
Now you know our age. Yeah, same team. Yeah. He was the best player on the team. Any further comments? Anybody online? Nobody? Oh, Mr. Bullock, come on up.
Mr. Chairman, committee members, Eric Bully with the Wyoming Hospital Association and also with Leading Age Wyoming. From the Wyoming Hospital Association perspective, the amendment that we made in section 1, we think is a good fix to something that I didn't even realize had happened during the interim. We feel strongly that having the Department of Health approve our plans for any healthcare construction makes sense. It saves us millions of dollars on the back end. There's some differences in regular construction versus healthcare construction, and we fall under a different licensing requirement when it comes to life safety. And so that amendment ensures that as we start construction, as we put plans in place, that the facilities we build are in compliance with the life safety standards. And it eliminates, or hopefully at least it minimizes the chances of us having a major change order at the end that'll cost us millions of dollars. So we're in full support of that amendment, which is in the engrossed copy. So also from the Hospital Association, we have some issues with this complete repeal. And as you look in the sections, when it comes to new construction, the 30 highway miles, not only does this affect nursing homes, this also affects critical access hospitals that have swing beds. And for those of you that live in rural communities, and there's only a couple of you on the committee, those swing beds are what keeps those hospitals open. And that's Medicare recipients that need skilled care in their facilities. So we have some issues with that one. from Leading Age Wyoming, which is a long-term care association, I represent about 2/3, almost 3/4 of the nursing homes in the state. We're opposed to a complete repeal. There are provisions in here that are repealed that there are already exemptions put in place. So governmental entities don't fall under certificate of need. And we've seen an example of this in Buffalo. Just a few years ago, we debated this idea heavily when the VA wanted to build a federal nursing home that the state would then take over. That nursing home has now been built. And what we've seen happen in that community in healthcare is that we had an existing nursing home that was attached to the critical access hospital up there, almost brand new when it was built. It's one of the most beautiful nursing homes in the state. It overlooks the golf course and the Bighorn Mountains. They are now at 60% occupancy. One of their 15-bed wings has been not shuttered, but can't take patients because there's not enough staffing, because we're now competing with a state-run facility that also needs to staff. So does the free market work? I don't know. We've seen nursing homes closing in our state. We lost a nursing home in Basin. And luckily, in this case, there is a state-run facility, the retirement home, that was able to absorb some of those patients. The problem with that is that facility is one of our safety net facilities in the state. It actually takes some of our hardest to place long-term care residents, and they're treated there. And we use that as a safety net. We're grateful for that facility. And I'm not even upset about the VA nursing home, except for the fact that it shows that it's not really, the free market doesn't always work. They were able to work their way around certificate of need. And now we've got a nursing home that the citizens helped pay tax money to build, and it's failing right now. A couple other things I just wanted to talk about. When we talk about free market, healthcare really isn't a free market. We can say it is, but it's not. If we want to have nursing homes and hospitals thriving in our rural communities, we've got to do something to protect them. The last thing we can do is allow them to be cannibalized. We've seen examples of this. In Utah, there was a moratorium that was lifted. And so they had a certificate of need. They lifted the moratorium, and there was testimony that was provided in Saratoga about this. What we saw in Utah is that there were nursing homes that were built that came in and competed and took the highest paying residents, the Medicare residents, and that moratorium was lifted for 4 years, but it damaged and actually drove the cost of healthcare up because the others are taking care of what we're taking care of right now. 70% of our residents are Medicaid patients. The others are private pay. So you throw another one into the mix, it's going to fragment the market. You can compete for sure, but what you're going to have is 2 failing nursing homes potentially because there's not enough staff to go around. We've talked about this. Saratoga is a good example, but it's not an accurate example. So in Saratoga, there was a nursing home. There was also a nursing home in Rock Springs that was owned by a company that went bankrupt. They washed their hands of it and walked away. The state had to step in and save those 2 facilities and run those for a period of time before they could find operators that stepped in. And what happened in Saratoga, it's no longer a long-term care, it's no longer a nursing home. It's now a part of the critical access hospital. And they've gone through a different configuration of how they're reimbursed, but they're now being paid through Medicare and Medicaid to have those patients basically in swing beds, which is what keeps critical access hospitals open in communities. And we're seeing a push towards that in many of our communities. So we're not seeing an expansion of the market, we're actually seeing a constriction of the market. And it's because if we look at the market, there's no desire to come to Wyoming. For 10 years, nursing homes rates were either frozen or decreased. We finally, just this last year, saw an increase in our reimbursement that gets us close, 80%, maybe 85% of what our actual cost is to deliver that care. We're still operating at a loss every single day for every single Medicaid resident that we care for. So our market's not that attractive, and I'm not sure lifting certificate of need is going to change that in many of our areas. So we have examples. We're lucky. If you're here in Laramie County, if you're in some of the other big markets, you can probably support and sustain additional nursing homes. But in our small rural communities, it's going to be very difficult. And what we might see is what we've seen in hospitals and that's cannibalization. We see imaging centers come in that compete against hospitals for imaging. They're able to do it cheaper because they don't have the overhead. But what it actually does is drives the cost up at the hospitals because we're trying to build economies of scale to lower the cost. But if those necessary services for emergent care aren't covered by the patients that are seen in the hospital because they're going to other areas or surgical centers or whatever it might be, it actually doesn't decrease the cost of healthcare, it increases the cost of healthcare because we have to support and sustain those facilities. I see the same thing happening here. So a request or an idea, instead of repealing this thing completely, and a couple of the repealers really don't make any sense because they don't apply to our state anymore. But when we talk about the 85%, instead of repealing it completely, let's adjust it and see if we see a demand increase in the state. Let's lower it. Right now, our nursing homes are running at 60 to 70% occupancy. So let's lower it a little bit and see if it makes any difference. And then we can come back and revisit this. If not, why don't we put a sunset date in place? There's already a talk about reporting, but why don't we sunset this and come back and look at it in 5 years when it's not a budget session? And we can really have some conversations about it. Finally, and we can spend all kinds of time if you want to talk about nursing homes. We didn't really spend much time on this in the interim. I'm sorry to say, we didn't look at what other states are doing. We didn't really study what's happening in our market. We had a few very brief conversations. The next thing I know, we're repealing this certificate of need. I agree that the existing certificate of need has some issues that our nursing homes have faced that have made big investments in our communities and in our state. When it comes to expansion, it's very difficult. One of the reasons we needed to look at this is during the pandemic, there was federal funding that became available both through CARES and then through ARPA funding. Because of the tight timeline on CARES funding and the need to get it out and spent, nursing homes really didn't have the opportunity to even apply for the CARES funding. But ARPA gave us 3 years to take a look at what we could do in our communities and potentially improve the quality of care and give residents in those communities private rooms and other things. But because of certificate of need, the nursing homes could only expand up to 10% and capped at 10. So a nursing home has 25 beds, they could only build 2 beds, 2.5 beds. If we look at economies of scale, some of ours are greenhouse facilities. They build in pods of 12. So even if they had 100 beds, which they wouldn't, they'd have 120 beds, and they wanted to expand, 10% would be 12, but under this, they're only allowed to build 10 of the 12 beds. So there are issues with some of the formulas in here that were come up with years ago. We could spend a lot of time talking about this, which we didn't do. And so my other thought is let's take it to the interim and really talk about this in depth and see if it makes sense. As we talk about what's happening in other states, there have been repeals of certificate of need for hospitals in many other states. Certificate of need for long-term care, most of them are still in place. And they're being debated all the time. And there's a reason for that. That's because we need to have adequate care in our communities for the aging. And you guys are aware as much as anyone that we're the second oldest state demographically in the country. But overbuilding isn't going to be a good thing. In our small communities, the last thing we want to do is have 2 failing nursing homes. We don't want to have 1 failing nursing home. We don't want to have our hospitals fail. So I would just urge caution and ask that we do something here that isn't a complete repeal, but maybe we look at other alternatives. And I'd be willing to suggest amendments if there's any interest in that. With that, I'd answer any questions. Thank you.
Question, Senator Dockstader.
Thank you, Mr. Chairman. You talked about dropping the number of beds down to a different percentage. What would that be, just off the cuff right here?
Mr. Boley.
Well, Mr. Chairman, Senator Dockstader, I think, well, let's put it this way. I think the reason 85% was agreed upon, and I have no idea, it was before my time, is because it takes 85 or 90% in our nursing homes for them to be solvent. Right now, they're at 60%, and most of them are struggling. That's why we lost one in Basin. That's why I have others that are considering whether or not they shutter. That's why I have others that are considering doing what we saw in Saratoga and bringing their long-term care beds under the hospital. The unfortunate part there is that with critical access designation, you're only allowed to have 25 licensed beds. So we might see a constriction of the market in those communities to try and stay solvent. You know, if we went to 70%, it might be, again, it's throwing a dart at the dartboard and seeing where it lands. But if we lower that amount, maybe that gives us an opportunity to see if there's more interest in our state. And I think if we have the Department of Health report back to us, and maybe we don't have to wait so long, but see if it even sparks any interest.
Follow-up.
Couple of follow-ups. You talked about Buffalo. We had a situation where a home was already there, state ran home, came in, the existing home was there. Is that a district that runs that or a private entity?
Mr. Chairman, Senator Doxer, it's part of the hospital district.
So our state is in competition with our hospital district. Is that correct summary?
Mr. Bowley.
Mr. Chairman, Senator Doxer, not necessarily because it's specific to the VA, but they are in competition for the personnel.
You're fine.
The other thing, and honestly, we've spent millions and millions of dollars on 2 state facilities. We've got the state hospital and we've got the Life Resource Center. Life Resource Center is an important component of healthcare in our state, and there's going to be a shift of patients from the state hospital to the Life Resource Center in Lander. It's needed, but we've also seen competition there with the existing nursing homes fighting for the same staff. And when we look at the shortage of staff that we're facing, and it's only going to get worse, I have serious concerns about what we're going to see in the future.
One more if I could, please.
Go ahead, sir.
A nursing home facility out west, they said if they could move that facility in under the hospital, and I don't tend to understand all of it, but they can move it underneath their hospital, it's $1 million plus savings every year. Does any of this address any of this, or is that still a question that's out there? I'm thinking about the nursing homes that I've spoken to, tied in with hospitals, and they said the nursing home, while absolutely necessary, is a drain on the finances of the hospital.
Mr. Bowley.
Mr. Chairman, Senator Doxter, and I've been working on that situation, and we actually have a meeting set up next week to discuss it. So there is cost savings, honestly, because a lot of the services can be shared with the hospital. They also receive some benefit under their cost reporting. And so we actually think what they receive now for a Medicaid patient as a nursing home will go down under Medicaid reimbursement for swing bed, basically, but they'll make it up on the back end when their cost report is settled each year.
Thank you, Mr. Chairman.
Further questions, committee. Senator Hutchins.
Thank you, Mr. Chair. Mr. Bowley, we were talking about 35-906, where the percentage is 85%. You said possibly we could change that to keep it and change it to 70, but it says 85% or less. So can you help me understand that?
Mr. Bowley.
Mr. Chairman, Senator Hutchins, so if it's 85 or above, they can build. If it's 85 or less, they can't build.
Gotcha. So you would, excuse me, Mr. Chair.
Go ahead.
You would like to have that amended to 85% or above?
Mr. Chairman,
Mr. Bowley.
Senator Hutchins, I'd actually like to lower that threshold. If we're going to do something, instead of repealing it, if we lower the threshold, that would allow, if nursing homes have an annual occupancy of 70% or greater, a new nursing home or another entity could come into that market. As opposed to 85, which is a higher threshold.
Gotcha.
Okay. Further questions, committee. Seeing none. Thank you, sir.
Thank you.
Anyone else in the audience wish to testify? Welcome to the committee. Go ahead and introduce yourself and go ahead and tell us everything you know.
Chairman and committee, I'm Carolyn Passano with the Wyoming Healthcare Association. It has both profit and not-for-profit members and one assisted living. I won't reiterate a lot of what the Hospital Association representative has said, but I do agree with it. I will bring up a couple of other things Actually, this bill is a year too early. I have 1/6 of my members that have recovered from the COVID era. That means that they are not full. They are not, and part of that reason is we have a terrible work staff shortage for nursing homes in this state. It isn't just nursing homes. You know as well as I do that there is a workforce shortage in every entity, different entity that you can think of. It might be restaurants, it might be the dog pound. But in nursing homes, we can only have enough residents as we have staff to make them safe and to have quality. So we are not full. I have 2 that are up to the point where they were before COVID. As I said, this bill is a year early, and we hope you look at it again in the interim, and that you bring in others like workforce services, like the Board of Nursing, like A&I. Bring in the counties and see where new people are moving in. If my friends in Sheridan were correct, they have a lot of California people coming. I don't know. I don't have a nursing home there. I don't know that, what's happening there. But we need the information with correct data to make a decision. I believe this is premature. House Bill 24 is actually premature for about a year. We need time. One of the issues that we are facing and have no idea how it's going to end has to do with the federal government, with a mandate on staffing levels. Until that actually is completed, which I'm guessing in a year from now when we come back for the full session, that isn't the budget session, we should have an answer to that. Wyoming, as all of us in the room and at home know, has the least population in the United States, which means finding enough workforce is difficult, if not impossible. And now we're talking cost. We do have to use traveling workforce. Very costly. We're not in charge, they are. They say what they need for a nurse's hour, and we pay it. I heard the Department of Health talk about nursing homes that aren't as good as other nursing homes, and used a harder word than I'm using. But it's their work in the survey that says what a nursing home has to rise to. And if a nursing home doesn't rise to that level, then they are very much in trouble, and we would expect them maybe not to stick around. I was confused with that testimony because that's on their hour to tell us where we're not doing well and how then we have time to come up to a level that is acceptable. I could go on, I guess, and give statistics. I don't think that's really necessary at this time. I'm asking that the bill actually not go forward and that we use the interim, that this committee study all of those issues, give nursing homes the time to gear back up after COVID, and you know that they were hit hard. And it is a kind of a confusion to me that we are going to put the cart before the horse. In this state, we're pretty practical. Why would we pass a bill, look backwards to see if you did the right thing? Why not look at what the data and the stats say and come back in the session a year from now and make that decision on what really does need to happen? Thank you.
Okay. Questions for Ms. Passano? Senator Bouchard.
Thank you, Mr. Chairman. So I'm going to ask the tough question. So if we have 60% capacity, why would a developer or investor come into an area and even try to put a place in Wyoming when they could do it in a place like Florida? And that's because I'm looking at the free market. And also, one other thing, wouldn't you agree that Buffalo was not a free market decision? The legislature voted to put that nursing home there. That wasn't a free market example that Mr. Boley used. So, I mean, I'm a free market guy, so I'm trying to get to the answers here. So one question was, why would an investor come into a market where you didn't have the capacity now? And two, if they were really free market investors, why wouldn't they go to Florida? I mean, so is this really as big a scary monster as we think it is?
Ms. Passano.
I would answer you. One of the points that was made earlier today to you was that the nursing home in Saratoga moved into the hospital. Actually, that was my nursing home, and the reason that it failed is because there were not enough seniors to put into the nursing home. It could not rise to the point of capacity where you weren't negative in the dollar field. We need to look at data. That is my answer. We do not have, you do not have before you the data that is needed to make a logical decision at this point. I do not believe. And we need to talk not just dollars. We must talk quality. We've got thousands of senior citizens in nursing homes. They need quality. They need safety. And we got to talk about that. And that is part of the data that you are wanting.
Further questions, Senator Bouchard.
Follow up. So I'm not familiar with what happened in Saratoga. So who made that decision out there? Was that?
That's a complex topic. So
Well, I just want the
you won't
simple.
come to an easy
I
answer
want the
here today.
simple answer. Who made that decision?
Go ahead and give us an off the top example. Don't try to go in depth. That's more than we're going to consider today.
My member made a decision that it could not make enough money. And actually, that member was a part of the hospital gearing up to take that nursing home into the hospital. Dollars from my member were put into that. Yes, it was a decision by the owner.
Yeah, it was a nightmare. That means Senator Barlow, I believe, was with us one. No, am I the only one that was, you were there? Yeah, it was not a good situation. Anyway, further questions? Senator Hutchins.
Thank you, Mr. Chair. Mrs. Passano, a quick question on what the previous presenter before you suggested, removing the repeal on 352906 Charlie and making the change or amending it to 70% or greater, does that help this bill in any way in your eyes?
I support that suggestion.
Okay, thank you. Okay. Thank you for testifying. We appreciate you having here. Anybody else in the audience wish to testify? Going once? Going twice? Okay, anybody online? Nobody online. Committee, what's your pleasure? Silence. Anybody wish to move the bill? Anybody? Okay, moved by Senator Bouchard. Anybody wish a second? Let's go ahead and move without a second and just discuss the bill. Can, committee discussion.
Mr. Chair, when you have the hospital saying, well, we don't really have a really definite no or yes on it, and then you have people coming up that we know are affected by this, and they're concerned, I would like to move that amendment to strike Charlie on lines 2 on page 2, or 12, excuse me, on page 2, and change that threshold to 70% or greater. And if we're gonna pass this bill, I'd like to see that amendment in there.
I don't believe you need to change it. Just change the 85 to 70% is the need, change that would needed by your proposal.
Say that again?
Just we need to change the 85 within that.
Yeah, but you need to strike on line 12, that
Right.
C.
Right. Repeal it.
Thank you, Mr. Chair.
Go ahead, Senator Barlow.
Thank you, Mr. Chairman. On the motion for the change, and our legal counsel is not here, but even though it's in the repealers, I don't know that's within the bill title to alter that, but I'm not going to make any judgment on that. We can move
Yeah.
through this or not, and I know my two colleagues have concerns about bill titles, but let's be clear. But my question is, and I apologize, Mr. Chairman, I was cross, what is the current average across the state of occupancy? I think we're talking about with this change, 85 to 70, and I apologize, I wasn't here. What's the current occupancy rate average across the state that this is trying to get to, Mr. Chairman?
I believe that we heard between 60 and 70%.
Thank you, Mr. Chairman.
He held up fingers. That was good. Okay. They agree.
Mr. Chairman, if I
Go ahead,
could.
sir.
And another thing from the testimony, maybe it's bringing the Department of Health back in. There are 3 carve-outs in the repealers. One is for federal VA facilities, one is for state facilities, and one is for 10% or 10 beds. So how much expansion, was there any testimony about the expansion of federal VA-type beds, state beds, and to the point about the Buffalo skilled nursing facility, that probably falls a little bit to the wayside, or any entities that have done the 10%. 10% plus 10% plus 10%, as you compound it, you can expand a facility relatively rapidly, double it, short amount of time if you do 10% at a time. So has there been anybody utilizing that mechanism to get around the 85% current threshold? Thank you, Mr. Chairman.
Director, go ahead and address that if you would.
Mr. Chairman, Senator Barlow, a couple of things there. So our last certificate of need waiver request or application was in 2017. I believe that year we received 2. We provided that data to the committee during the interim discussion to give you a brief history of what we had reviewed in terms of certificate of need and what we had approved and denied based on the statute. Happy to shoot that to you all after we meet here. But as I mentioned in my testimony, the volume of requests was relatively low. We also have seen requests going back to 2009 where a certificate of need request was made, it was approved, but then no expansion or construction project happened. A different decision was made. In terms of the exceptions that you mentioned in the bill or in the repealers, you're right. State facilities are generally accepted, are exempted from certificate of need, primarily because of the specialty populations that we serve. Whether you look at the state hospital in Evanston, the Life Resource Center in Lander, or the Veterans Home in Buffalo, which was mentioned, which is a facility, assisted living and now nursing facility that serves specifically veterans and Gold Star families. eligibility criteria to get into those are really service, which other facilities who might admit or accept veterans don't just serve veterans. So those exceptions were there. If it's repealed with the repealer, again, no issue here because the legislature still retains the authority ultimately to either expand or not expand our facilities in the Department of Health for our safety net populations.
Thank you, Mr. Chairman. I'd like to know how many requests for waivers you've had over the past 10 years and maybe specifically where they were so that way we can understand what's going on. I mean, do you see this when they do these requests? Is there a need there that that's being missed? I mean, I get the whole protectionism part of this, but I am a free market guy, so I mean, I got to look at real data to try to figure out why we're even having this discussion.
So how many in 10 years? Go ahead.
Mr. Chairman, Senator Bouchard, I don't have those numbers off the top of my head. 5 minutes after we leave here, I'll shoot you the data for what we've seen. I believe what we prepared was going back 15 years to 2009. Again, relatively low volume, but we'll shoot you that as soon as we can this morning.
Okay, thank you, Director. Oh, one more question. That's what you get for coming back up. Go ahead, Senator.
Thank you, Mr. Chairman. And just because you're here, what do you think about the request to make the threshold 70% or greater? What does that do for you?
Go ahead, Director.
Mr. Chairman, Senator Hutchings, I'm going to apologize in advance for my wishy-washy answer here. Again, your department is neutral on this bill. There's just policy pros and cons and a lot of hypotheticals that I think we don't know on the potential impact of a full repeal or even a reduction in the threshold of what the certificate of need occupancy requirements are. I think given right now our statewide average occupancy of nursing home beds is around 70%. So if you reduce the threshold to 70% on a statewide basis, and here's where I'll confuse you and I apologize, on a statewide basis, you would think, well, not much impact there, right? But it really does vary community to community and geography to geography. With that, 30-mile radius, highway mile radius, it is very different when you have, a smaller community with 2 nursing homes than when you have a larger community with 4 nursing homes. So I'd struggle to answer specifically, Senator Hutchings, on what the direct impact would be. It's just a difficult hypothetical to answer, but I'm sensitive to as I mentioned in my testimony earlier, I'm sensitive to the concerns about certificate of need. I've talked to my counterparts in other states whose legislatures are also debating similar functions where, is there the state stepping into a market mechanism in certificate of need? Absolutely. That is the root of it. Is that appropriate or not is a more difficult question, especially when, as I mentioned before, your primary payers for long-term care are public, either federally taxpayer-funded Medicare dollars or federal and state Medicaid dollars that fund long-term care reimbursement. That's a tough pickle to be in when you want to take barriers off of free market mechanisms, but the vehicle to finance those expansions or new facilities would in essence be public payers, and public payers in our dismal economic terms have what we call monopsony power, which is the power to purchase, and Medicaid and Medicare are your big purchasers of long-term care. Mr. Chairman, members of the committee, does that mean repealing certificate of need in Wyoming would lead to dramatic cost increases in Medicaid and Medicare? I doubt it in the short term because of the discussion you all had over the interim and this morning that are Wyoming markets for long-term care attractive for additional expansions or new construction of nursing homes. Again, I would say in the short term, probably not. But it's a difficult question to answer, especially the dynamic that I mentioned before, where you have facilities that have a sort of natural market signal of demand that want to expand, and in some cases, not all, can't because of a certificate of need, because their peers in that geography are at lower capacity than they are. Those situations don't present themselves often. Again, I think we had both an expansion and a new construction proposal in 2017, and we'll get you that data on what that looked like. But it's a tricky policy decision here. Like I said, whether the legislature ultimately elects to repeal the certificate of need and look at it over the coming years, that's certainly an option. And your department stands ready to provide you any data or reporting that we can to explain how that's going and what we're seeing in those market dynamics, for lack of a better term, or reducing the threshold to potentially allow those expansions in a broader capacity than just an 85% threshold is another option. So, Mr. Chairman, Senator Hutchings, I gave you forewarning that I'd have be straddling this fence post a little bit here. I apologize.
We're gonna allow one more question before we let you go sit down. Senator Barlow, did you have something?
Thank you, Mr. Chairman. So, and I apologize, committee, I'm asking questions that you probably have covered, but when I look at the intent of this, it's nursing care facility, and I think in my own mind, I have erroneously thought only skilled nursing facilities. And actually, by definition, nursing care facility is assisted living, nursing care, rehabilitative care, and other related services. So I guess this is beyond just the skilled nursing issue. And is it, so in those other types of skilled nursing, I think you maybe had 3 or 2 in 2017. What about in the assisted living in that realm? What are we at with occupancies in that realm? Thank you, Mr. Chairman.
Mr. Chairman, Senator Barlow, again, might warrant some follow-up in the minutes to follow this meeting to confirm some information. My understanding is that we only apply the certificate of need rule to skilled nursing and nursing facilities. We do have, most of our nursing homes are skilled nursing facilities. We do have some, to your point, that are not skilled and essentially are not really chasing the Medicare rehabilitation dollars, and what we call NFs or NIFs, nursing facilities only. I'd have to follow up with you on whether we have or whether we do apply certificate of need to assisted living facility expansion. I don't believe that we do, but let me confirm that.
Go ahead.
Thank you, Mr. Chairman. Well, I certainly appreciate the any follow-up, because when I look at the definition, it certainly includes assisted living care. Now, maybe there's a definition I'm not seeing, but in a rule-based something, but certainly a follow-up on that, because I want to understand the full context of how this could be or would be applied. Thank you, Mr. Chairman.
Okay, with that, we'll let you go. Sit back in your back row. Okay, further discussion, committee. I'm going to propose, oh, go ahead.
So, Mr. Chairman, on the amendment, I think if you're going to bring in B, and move that from 85 to 75, you also have to retain the definition of construction area. Otherwise, it does not work with so you have to remove both repealers and make the amendment from 85 to 75. As a respectful suggestion to the committee, if we're going to proceed with this, I think there's a little more to do and understand about it. Thank you, Mr. Chairman.
I was going to make a proposal in committee. You can take this or leave this or say you're an idiot, Chairman, whatever you want to say. But my proposal is that we consider tabling this and moving this forward to an interim discussion. I'm not seeing the necessity for an urgent or an emergent passage of the bill. And it sounds like we're getting a lot more questions than answers. That's just in my mind. And that's, I mean, it's on you. If you wish to entertain that motion, speak up. If not, let's move ahead.
Mr. Chairman, if that's a motion, I will second it, and then I'd like to speak.
Okay, so it's been motioned and seconded. Go ahead.
I appreciate the testimony that it's good for business, but having attended more hospital board meetings than I care to remember over the years, this is a difficult area, and it is not getting any better. And we just had our representative of nearly 30 hospitals across the state step up and say, wait a minute, let's slow down, let's reassess this, let's take a better look at it, because we may run into a deeper problem than what we want if we try to push this forward. But that's part of the process. We run it through the interim, we talk about it, we run it back and forth between both ends of this building as we get ready to go to the floor. I'm not comfortable giving an aye vote, so I'm with your proposal to table.
Other discussion? Senator Bouchard.
Thank you, Mr. Chairman. So the only thing that I see that we could discuss that is a problem is that you have the facilities that just chase the government money. And I don't think those are the ones that were in effect with this bill. I mean, I think that anybody else that comes in to build a new nursing home would probably do a hybrid where they were doing something where they're chasing some federal dollars, but I mean, free markets make things better. They make a better nursing home come in and maybe, you know, and I hate to say this, but some of the ones that are there, they've been there a long time. I mean, look what we do to schools. We tear down a perfectly good building, we build a new school so we can have a Taj Mahal in there. So now all of a sudden we're saying this one, we're gonna say, nah, we can't do that. So that's where I'm having the heartburn here. I don't think that even if we did pass this, I don't think we're gonna and the sky's not gonna fall. I mean, and then if it does, we're gonna be here to pick up the pieces and figure it out. So I mean, it's just not, this is almost like rent control is what this is. This is the same kind of concept that we're gonna protect everybody, but then we're gonna create a bigger mess. So, and just like the Buffalo thing, we did, if you remember, I was the guy saying we shouldn't do Buffalo. I went there and visited that nursing home, and that was a political play with arm twisting, and, you know, everybody wanted it. Some people wanted it where they wanted it. That's what's wrong with government being involved. So.
Okay, on the motion, Senator Barlow.
Thank you, Mr. Chairman. I'm going to support the motion to table. And like a lot of things, we create problems in government, and sometimes we don't pull the right levers to repair them. We want to repair a lot of this. To my good colleague's point, we probably need to actually address the reimbursement rate that we pay for folks in these facilities through Medicaid. That's more dollars in the system. So then you have other players in the system that are interested. But when 70% of our beds are paid for by government dollars, that's a big obstacle for those providers out there. So I'm going to support the motion to table. My query to the chairman is, this will be put forth as a topic for management council to consider whether we continue it.
Yes.
And quite honestly, I'm going to suggest to management council when I engage with them individually, that we may not want to continue it, Mr. Chairman. So that'll be their decision. Thank you, Mr. Chairman.
Okay, further discussion on the motion. Okay, we have a motion on the floor. All those in favor that we table this and move it to interim, or suggest it for the interim, say aye.
Aye.
All opposed, say no. Okay, that motion has passed. Help me out, former chairman or other chairman. Do we now need to do a roll call on this and consider as a do not pass, or for the record?
Well, Mr. Chairman, I think it's just not reported out of committee. That's where it stands. It just stays in committee. I don't know. If you want to have a motion do not pass, it still goes to the floor and still goes on the committee of the whole. But I don't think it's necessary, Mr. Chairman.
Well, I just think it's always good to put our name on a vote one way or another. Thank you.
I'm neither here nor there. Let's go ahead and do a roll call and do it and then we'll do it as a do not pass. No. Yeah.
So, Mr.
Mr.
Chairman,
Chairman, we're in a little bit of a strange spot here. We already had a motion to table. Now we're asked, you want us to have a motion to do pass, and then we just vote no on that.
Let's just do this.
I think it's tabled.
Since we passed that motion, let's do it as a table. That way it just doesn't need to go to the floor at all. So, yeah, no roll call. Thank you, committee. It looks like I called our time about right. And reminder to all those in the audience that the deadline is coming up on Friday for interim topic submissions, so you need to get those in. If you've got any ideas, pick your favorite legislator and